Okay, it is 1 o'clock and it looks like the waiting room is cleared. I have Ron, Matt, Roseberry, and Meredith. Did I miss any other committee members as they were logging in? I'll turn it over to you, Ron. I think we lost Ron for a minute. Let's see if he logs back in.
Yeah, I was just about to say that.
He's logging back in now. So if we give him just a second, he should be back with us.
Sure.
Okay, can you all hear me?
Yes.
Yes, sir.
All right, I don't know what's going on because I've got direct internet. Anyway, I apologize. I got bumped off and then I still don't see the full screen of everybody else, but I don't know why it's so wonky for me today, but anyway.
It's
I
been
mean,
happening to a lot of people today, on and off meetings. So
okay.
be happy you're not alone.
All right. Okay. Welcome everybody. Sorry about that. And we got Matt, Meredith, Rosemary, and who else did you say? Because that's about the time everything froze up on me.
Jill logged in.
Oh, Jill's in there too. Okay. All right.
Hi, everybody.
Hi. So we've
So,
established a quorum. Uh, do we have any changes to the minutes from 8/9/23 meeting?
Ron,
Karen,
since your camera is not working, if Jill can turn her camera on, that should still give you a quorum to be able to vote on camera. That still gives you
okay.
enough numbers
Well,
since
Okay.
you're having camera issues.
well, see, my problem is if I can, I don't see my little box that's got my name on it to ask for video. That's the whole problem. Here, hold on.
Maybe your screen is minimized. You need to maximize it, and it'll pop up.
I mean, it's
Mine's
saying,
across the bottom.
You still have a quorum with enough members if you can't get it on.
well, I'm trying my
I can see you, Ron.
Yeah, we can see you now.
Did we lose Ron again?
He's still logged in, but a phone number just logged in. Sometimes people log in on a phone and a computer, so I don't see that it dropped him.
Okay.
And it looks like he's gone. We did drop him this time.
Okay. We can give him a few minutes.
I don't see that he is logging back in. I'm not sure. Do one of the other members want to start down to through the agenda until maybe he logs back in?
Sure. I guess we could try to handle it, huh, Matt, Rosemary? I think
Sounds
he
good
would,
to me.
yeah. I'm welcome to hand it over to anybody else, but
Please.
okay. Okay, so did we approve the minutes from the previous meeting?
Not
You
yet.
have not. If Jill can turn her camera on, you should still have a quorum. Or I'm sorry, not Jill. Who do I not have on camera? There's Rosemary. Meredith is not on camera.
Well,
Yes.
Oh, there she is. Thank you. I had to scroll. My apologies. I see you now.
I was like, I see myself. So
Okay, can we get a motion to approve the minutes from the previous meeting?
I so move.
A second?
second,
Any negative votes? Minutes from the last meeting are approved. And now I'm going to kick it over to old business. And Matt, I think you wanted to talk about the Senate Bill 50 savings report, which came out yesterday afternoon. I haven't really had a chance to go through it completely. I think we've been looking at it.
Yeah, Jill, that's understandable. I was gonna say, it'd be helpful to provide any questions in writing, so we can take a look at it and answer those questions in completion. I think, if there are questions, we can try to address them here. But with the length of the report and how detailed it is, it might just warrant a separate meeting altogether.
Yeah, and I do want to put the floor over to Matt, but I read part of the in brief, and it seems like the conclusion was in the first year. I mean, I guess I was kind of surprised because they were still doing a per member per month calculation. I kind of thought it would be just a savings calculation, but I think that said in 2021 there were some savings, so significant savings, and then costs were back up in 2022, but that was not due to the reforms. It was due to other factors that include brand over generic, COVID, drug prices going up. That is all that sort of caught my attention. I realize that there's only a couple ways you can do that, and probably the folks that did it were limited, but I was really hoping that there'd be something we could use, something that the PBMs don't try to latch onto and use against us as we try to make reforms, further reforms here and in other states.
Right. And I think the most important thing to note that we've been alluding to for quite some time is that, number one, it's not an apples to apples comparison. And number two, there are just so many different factors that play a role in this type of model. And other states are trying to move to this model or something similar, and it's hard to quantify and say, okay, we saved X amount of dollars with this program. There's just too many factors, and especially COVID just puts a dent into it as well. So lots to consider, and just the changing climate, the increase in drug prices overall, inflation, so on and so forth. There's just a lot. But I would agree with your sentiments, Jill.
Fatima, I think I was told that at the Joint Committee on Health Services meeting where this was discussed, that one item, and I haven't had a chance to look at the full report yet either, but one item that was discussed at that meeting was about the rebates. And I think I was told, I apologize, I wasn't on that meeting. I had surgery that day, but I think I was told there was a savings with the rebates in the $1 billion range. Do you happen to remember? And maybe that's a question you can come back to us and tell us about, but do you happen to remember that exact figure that was mentioned during that meeting?
I can go back and pull it up. I myself was traveling that day, so I wasn't on the call, but I can certainly pull up my notes.
Okay, that would be one thing I would want to look at.
Mm-hmm.
I think it was a little disappointing that we didn't discuss the impact that has on the pharmacy community. I think the savings are great, and that's what we all want, right? Is the state to have savings. But there's certainly a component of cost that those, as we've all discussed on this meeting several times, that there's the pharmacy that comes at a cost to the pharmacy. So I want to make sure we continue to hammer home that point.
Absolutely. Yeah.
Matt, did you have any comments?
No, I mean, the point I was bringing up is just when we were going to get it. And like everyone else, I was staffing yesterday, so I only got to scan. And this is definitely a report that deserves more than a scan. It deserves a lot of time for digestion. So I think a follow up on any questions we have and specific questions we should probably submit before next meeting so everyone is ready to have answers. And I mean, my point was just when we were going to get the report, we received it. Now I think we just need to have a little time between meetings to read, digest, and analyze, and we can follow up next meeting.
Yeah, so we'll probably need those questions in writing before that. So I don't know if you want me to send out a report to members after this that asks for what follow-up, what questions they have. Or if someone wants to reach out to Ron.
I definitely think a follow up with a few weeks ahead of time, a reminder to the committee with questions they will have would be good, just so they can get to the people that will have the answers, so they're ready for our next meeting.
Yeah. Well, NICDS will also do an internal analysis with our policy, with their reimbursement policy staff, to pick out the high points, and I'm certainly they'll have questions. So I'd be happy to share those with the group to help kind of guide. Any questions you may have, and maybe they'll break it down a little bit for us.
Good idea. Jill, I think I will send that out to our members too. I sent the report out yesterday, to our KIPA members, but no one's had time really to go through it. And as Matt said, we've just had time to scan it. So we'll all get together. I think if you'd like to send that out, I think that'd be great. Send it out for all of us to, have a deadline to send the questions in.
Do you guys know off the top of your head what our next meeting date is, so I can give them a deadline?
November 30th. Is that
Okay.
right?
Thank you.
Yeah, so preferably before Thanksgiving.
It looks like our next meeting is scheduled for December 13th. So yeah, November 30th would be a great deadline.
Oh, okay. I'm sorry. I thought the meeting was November 30th.
I thought it was too. Sorry.
Thanks, Matt. I couldn't get off mute fast enough.
I can probably look at the webpage and figure out when the next meeting is scheduled for.
Can you all hear me?
There you are.
December 13th is our next PTAC meeting. All right, where are we at before I get bumped off again? Because something's going on.
Ron, we had initial. We approved the minutes. We had a short discussion about the Senate Bill 50 savings report that came out late yesterday afternoon.
Okay.
Which is complicated and a long report, and there's a lot of if, ands, or buts and variables. So I think we're gonna have to do some digging through it to pull out the high points and the positives. If you would send that the report to the PTAC members and ask them to, if Fatima has asked us to get back to her ahead of the next meeting with any questions we may have for them to answer on the next call regarding the report. So give everybody a due date. And then I know that our internal policy folks will analyze that analysis. Whenever I have, I'm happy to share it. They probably will have questions that will be the same as others. And they may also, I'm sure that they will pick out the high points that we're going to want to bang the drum a little on.
Okay. And then I've even reached out to the sponsors of the initial bill, and they're still trying to gather information from the report. So it's a little premature to do much right now. So.
Yeah.
Okay. So any other comments about that report, or ready to move on? Okay. Our next topic there is the pharmacy enrollment on the vaccination for children. Both Matt and Jill brought this to my attention. So if either one of you all want to take off with your comments on this.
It was just brought to my attention that there was some misunderstanding about it, and Jill seems to be the expert on this. I'd feel more comfortable handing this over to Jill. She seems to be able to run with it better than I can.
Okay.
Okay. Hopefully I'm not wrong, because I had our lawyers look at this. I had a bunch of people look at this, and our members all believe that this is the case. So a rule passed several months ago, Medicaid rule, that took out language in the rule around VFC, around pharmacists having to enroll in VFC, and around having to use VFC stock. And when you read it with the deletions, it strongly appears that as of the date of that rule, which I can't recall right now, that pharmacists no longer have to be in VFC enroll in order to get reimbursed by Medicaid for children's vaccines. I, through emails just among this group, I believe that there may be thought that that is not exactly what's happening. It hasn't been. I don't know, Matt. I don't know what you're hearing. I have not had any complaints from my members so far, but that doesn't mean that they've upgraded their systems to start this yet, or just,
I was informed through KPHA that members were being told that they needed to enroll, and the VFC for this don't have specific examples. Is Ben or Shannon on the call? They a little more knowledgeable of the specific concerns that people were bringing up.
I mean, the intent of the rule said it was meant so that in the actual rule, and that, the rule analysis that came out of the commission said that that was the purpose of the rule, and that there was zero fiscal impact given preventable diseases and the savings that are generated by that by getting vaccines. So, Fatima, do you or anybody else at Medicaid are we interpreting the rule incorrectly? Do we know why our members believe that they still are being told that they still have to enroll in VFC?
I'm not sure to the latter point why they're being told they have to enroll in VFC, and I did ask one of our VFC experts to join this call. So maybe Erica, you can shed some light on the enrollment piece. But in terms of the stock, you are correct in your understanding that the stock can be used for a non-VFC member, for instance, so that there's no wastage. Erica, did you have comments on the enrollment piece?
Wait, the stock can be used for a non-VFC member. The way we read it, the rule is that the pharmacy doesn't have to comply with the separate stock rule that VFC imposes on enrollees.
Right.
Meaning that that Walgreens can take the stock of MMR vaccines that they purchased from, I don't know, McKesson, and use those they wouldn't have to use the stock that was already paid for by the federal government.
Right. So I guess then that ties back into the enrollment piece, because to our knowledge, we don't know of any pharmacies enrolled in VFC
Correct.
to this day.
Correct.
So,
and you're not alone. It's like that in most states.
Right.
Yeah.
So I guess then the stock question comes in where, I guess, would Walgreens even have a VFC stock to begin with?
No, but I think that the rule was read because of what was deleted, that not only was the stock participation, the stock change, but we know that pharmacies can give vaccines and be reimbursed by Medicaid for the full product, the product cost, and the administration fee, which just increased, but without having to enroll in VFC. So they should be able to bill the state for the product and the administration fee without being a VFC enrollee, because that's how you create the climate where pharmacies can open up and vaccinate more children and give more access.
Right. And I think it also ties back to Board of Pharmacy regulations, that right now the Board of Pharmacy has it as 9+ unless you have a prescription to enroll, like a 6-year-old or something. So I think that also plays a role here. And I mean, the 9+ has been in place for a while. So in theory, if a 9 or 10-year-old comes in for a flu shot or for a routine vaccination, as long as you're set to administer and you have all the education requirements completed, the pharmacist should be able to vaccinate that child.
And be without enrolling in BFC and be reimbursed for the product and the administration fee.
That is my understanding, yes.
Right. So Matt, and I mean, I would think that Shannon would have thought of this, but maybe the confusion is coming in because we have members trying to bill for kids under 9. Maybe they're confused between the PrEP Act and because the ACIP authority.
Yeah, I think the Board of Pharmacy has a good diagram.
Mm-hmm.
I can share that in the group. I'm sure you guys have seen it.
No, I mean, we would know that. I mean, you would know that you had to comply with what's allowed in the scope of practice today, which hopefully will change in 2024. So Matt, I don't know if that's part of the problem. I'm thinking that it goes beyond that. So
I will follow up and ask. I thought one of the two of them were going to be on here to shed a little more light and give specific examples. I will check into this, but takeaway message that I'm hearing is officially pharmacies do not have to enroll in BFC to give it to kids 9 and older. Correct?
That is correct.
Yes.
Great.
This is Joe. I've got a quick question, if I could.
Sure.
Okay.
So I'm trying to understand this. So are we saying the pharmacies can get access to the VFC vaccines?
No.
Okay. So it's not a situation where you're getting the product at no cost and then billing the plan.
No.
Okay. All right. I'm getting a little confused.
I think it's because pharmacies nationally, and we have been, my organization has been working with CMS on this, but hasn't gotten anywhere yet. And we work with some other states on trying to make VFC more palatable, and it's just so burdensome in a pharmacy setting, especially the way we're set up, how small the back area is, stock areas and all that. It just does not work operationally. It's another group of audits. It's another supply. Which is one thing that this rule did take away. But I don't know that there's a fix that a state can do without. I don't want to speak for everyone, but I'll speak from my members' perspective, the chains. I don't know that there's any little fixes you can make that would make pharmacies enroll in BFC, or that would make pharmacies comfortable with enrolling in BFC, because they just can't operationalize it into their workflow. So our understanding here is what was being done is we would no longer have to enroll in BFC, but could still get reimbursed for the product plus the administration fee.
So as a follow-up question to that, are the VFC, is there a reporting requirement, so it goes into the database, so you don't double vaccinate? Is there a requirement in VFC for that?
Kentucky has an immunization registry, I believe, that everyone has to report to. So it would be the same way we do kids vaccines for or any vaccine to date for other patients with same reporting requirements, same.
And I'm aware of that. I just want to make sure there wasn't anything separate. Okay.
No, it's not. It's state law would not. I mean, it would not be abrogated by the practice law would not be affected. It would just default to the way that we supply and bill for other vaccines to non-Medicaid patients. If that makes sense.
Got it.
Okay, so is there any further or any action or anything anybody would like to do on this, or is it more that we need Jill to work with Board of Pharmacy on submitting either another bill or look at lowering the 9-year-old 9+.
Yeah, I think that our organizations that represent us on the Hill there are working on that.
Okay.
I think that'll be a piece of legislation that we'd likely see introduced next session, but I can double back with Shannon and Ben on that. But let me also double back with Shannon, Matt, and Ben. Matt and I can do that on what exactly the issue was and clarify that we've clarified that as long as we are complying with our state scope of practice age requirement, we can bill for Medicaid kids vaccines without being enrolled in VFC.
Okay. All right. So is there anything else on that topic?
No, but that was a great move for access, and I want to thank Medicaid for that.
Okay.
If we can get through the confusion, I think that access will happen, right? There'll be more access because I think it sounds like there's some confusion among the pharmacies. So I don't know if it's something that, I know there was a rule that was put out. I don't know if there was any kind of bulletin that was shared interpreting the rule. Because it was a little confusing because you really have to go back to like the amended version of the rule to read it, to read what was deleted, to get the full meaning versus the final engrossed version of the rule. But
yeah, and if you can send us some examples, that would be helpful for us.
Examples of?
I think there were a couple of pharmacies that were having issues.
Oh, okay.
Yeah.
Yep.
Okay.
I'll take charge of following up with Shannon on those three things. What was the issues? What were the issues? Getting them written up to submit, and just double checking on having a vaccine expansion bill for 2023.
Okay. Aaron, are you on here with us?
Yes, sir.
Okay. I have sent a text or an email or whatever chat off to Zoom, and they're saying that I did join by computer audio like I usually do. I've started the video and did everything on my end. They said it's how you're accepted into the meeting. So I still don't see my box. I don't see myself on video or anything. So if you can just check into that while we're continuing the meeting, I'd appreciate it.
Yes, sir. I will. I just hit admit, but I will see if there's any issues pending on our side. So I can see you. Does everyone else see him?
Yeah, I think Ron, you need to hit. Do you have a little box that looks like a grid for grid view?
Yeah, I've changed the view 15 different ways.
Oh, okay.
It just won't show up. But anyway,
I'll look into it.
And it might be there's a little button when you go to that you scroll down and it says hide self view, and so maybe that got hit accidentally.
And where's that at?
Well, unfortunately, it's in my little box with my picture on it, so it's
okay.
So I don't know what to do if you don't have a box.
Okay.
But, Ron, I couldn't see you earlier, but I can now.
Okay.
Yeah, we can see you.
All right.
Ron, Ron, can you see all the people on the right side of your screen or the top?
Yes.
And if you look in the upper right hand corner, do you see like a little view?
Yes.
Click on that and see it, and in there there'll be like this hide self view.
Okay.
Yeah. There it is.
Yeah, there's Ron, the idiot.
There you go.
Who can't, or obviously who hits the wrong box. Thank you. Okay, moving on to 4C. The last part of that is wrong. I put two ideas into one thing there and I addressed it on down through there. So basically just the community health workers update. I know that just to let Fatima and Medicaid know that we are working on putting together information. I've sent some information to you guys of other states that there's a number of states that their number one community health worker are pharmacy technicians. I mean, the most prevalent. And it's for obvious reasons. It's just main thing is access. I found it interesting that the colleagues that have had this around for a long time and been accepted in their state, that actually their delivery people are huge in their community health worker program, because they are the ones going out and checking on people and delivering medicine and, seeing what their needs are at their home level. So, did anybody else have any other updates? I know I've been talking to a lot of people to try to get something to Medicaid to reconsider putting at least the pharmacy technicians on there to be eligible and to be under our responsibility as one of the providers that can have the community health workers. So is there anybody else that has a comment on that?
Ron, have you reached out to, it sounds like Missouri has a very successful community health worker in pharmacy. Have you reached out to them? If you haven't, I don't mind to do that.
I have. That's where I got most of my information, because they've got some that's been pharmacy technicians, that's been community health workers for like 10 or 15 years or longer. And, it's just a natural extension of their job.
Sure.
They still do the regular pharmacy tech work, but they also get more involved in the needs that can be met by the community health workers. So you're right. That state's kind of the leader on this. So yes, if you reach out to your contacts with Missouri also and see if they have something we can use to submit to Fatima and Commissioner Lee on this. Okay.
Okay, great. I mean, I think you're exactly right. We're the pharmacy community is poised to do this process. We definitely see the needs in our communities. So thank you.
And then the last part there, just FYI, I had that on the last meeting, but that's just contacts for MedImpact, and also how to look up the latest NADAC reimbursements that have been increased, where you can go back and bill. I've still tried to figure out a way to streamline it a little bit, but if I ever figure that out, I'll let everybody know. And then
Ron,
Ron, yeah.
Justin Derringer has his hand raised.
Oh, I'm sorry.
It's okay.
Go ahead, Justin.
Yes, sir. Hi, this is Justin Derringer. I'm the acting director for the Division of Healthcare Policy. I just wanted to talk very briefly, give a quick update on the community health workers for pharmacist question. We are currently reviewing and working on some of the material that you all had sent us, some of the material that we have gathered as well from other states. And so that's currently in review. And I know we had administrative regulation in the process, and we had received some comments, and we did make changes that would allow for that if that was the decision that was made moving forward. And so that administrative regulation, the change that was made to that administrative regulation would allow for other provider types to provide community health workers without having to go in and amend the regulation. So just wanted to let you all know that that change was made to the administrative regulation, so that opens the door for us to move forward when that day comes. And we'll be getting back with you all as soon as we come to a decision on when and how to include community health workers or pharmacies in a provider type that can allow for those services.
Okay. Thank you very much. That's great news. And you're getting our information, because I've been submitting it just into Kentucky Medicaid as the different emails I've had, and it seems like that I'm getting other people wanting to submit stuff too. So do you have a preferred contact or email address to send that information to?
Yeah, I'm gonna actually I'll give you I'll put a email address in the chat box, and you can funnel and forward all of that information to that email address. That will kind of ensure we get everything, and it's not all strung out through different communication lines, if that's okay.
Yeah, that's great. Thank you very much. Okay. Number 5 under new business, the Medicaid fee-for-service reimbursement for vaccinations. And Fatima, the only thing that I've it's not me personally, but I do have several long-term care pharmacists that they're the ones that's doing most of the vaccinations for most of the residents in long-term care are under the fee-for-service or Magellan. So it was just it's becoming a major request from people to see about how we can get that changed. So Matt, did you have some other comments?
You pretty much summed it up, just seeing if this is in the works. Is it something in the future? If it's not, what can we do to try to get fee for service to cover vaccinations at a pharmacy level? And those were about it.
Because it seems like, Fatima, that the doctors, it's actually the pressure from the doctors. They're telling me that they're like, well, wait a minute, you can do all these other vaccinations. Why can't you do this for me at the nursing home, or whatever facility that the doctors above? They're like, I need you to do this or provide this service for me. So anyway, just wanted to get your comments on that.
Sure. So we had a preliminary meeting about this maybe a month or two ago. I'm not sure if everyone on this call was on it, but I think the outcome of that call was mainly to send over some additional information for us to review and also conduct a fiscal analysis and see, what it would take to shift over fee-for-service vaccines at the pharmacy. As you all know, right now, those vaccines are administered at providers' offices and so on. So, with that being said, I think it was a thought pre-COVID, just based on some old notes that I was going through recently. And I think, I do think it's an appropriate time to bring it back up, especially since we're changing fee-for-service vendors, which I'll allude to towards the end of this discussion. But, I think right now we need to see what it'll look like from a fiscal perspective, evaluate other options as well, and just see what the scope looks like. I can't guarantee that it's going to be anytime soon because we are under an implementation right now, but I do think it's a topic for later in 2024 when we can get as much information and data from you all to really evaluate and make a sound decision, and also take a look at the fiscal.
Okay. So when do you think would be a good time to follow up in 2024? Would be first quarter, second quarter? When should we make a note to circle back to this?
I would say second or third quarter.
Okay. Thank you for the information.
Hey, can I just ask you guys, I'm sorry, what is the issue? Just in a nutshell with the fee-for-service vaccinations? I thought we just got an increase was just proposed?
That was for the MCO vaccines at the pharmacy. So for fee-for-service, our members go to their primary care office to get their routine vaccinations, except for COVID-19. COVID-19 is the one exception that they can get at the pharmacy.
Well, how does that jive with the new VFC rule that's supposed to apply to managed care and to Med Impact?
Well, it would apply at the primary care provider level, whoever is administering the vaccine. So right now we don't allow
you don't allow pharmacists to administer vaccines in the fee-for-service program. Is that what you're saying? Like it has nothing to do with VFC. They're just not considered a provider.
Right.
Oh, I haven't heard of another state that has that rule.
Yeah, and I mean, again, it was something that was explored pre-COVID, and then we were kind of thrown into a whole fire with COVID. So I think,
where we gave all the vaccines, where we gave 95% of the vaccines.
Right. So, I think
sorry, Fatima, I couldn't help myself.
No, that's okay. Well, I think, I think it's something to open up and reconsider. But again, we'll have to take a look at what the current landscape is, our primary care providers, successfully administering routine vaccinations for our fee-for-service members, how many of them fall into things like hospice, long-term care, that kind of thing. You know, how many members are truly going into the pharmacy to receive routine vaccinations or would like to. I mean, I know everyone's used to the current setup, so you know, we might not see too much of that. But again, I think there are a lot of factors here, and it needs to be opened up and just discussed in further detail.
Fatima, I know
Kathy.
that there used to be some data out there as far as percentage, but what percentage of fee for service are actual long-term care residents, or do you know that percentage?
Not off the top of my head, but I can certainly pull some numbers.
Because I've always thought, or was certainly in years past, it was, you know, quite high for those people to be in there. So that's where the big disconnect is, because you know, the physicians are coming there to see the patients or see the residents and meet their needs, but you know, they fully expect you know, the pharmacist to be able to carry out, you know, the vaccinations need to occur. And I do have some people raising their hand here. I don't know who is first, but Kathy, go ahead first.
Okay, thank you. I just wanted to bring up that there is a group that I hear many times, and I used to service many of them, is those group, you know, the group homes with the special needs patients. And, you know, what I'm hearing around the state is, you know, these individuals are reaching out to pharmacists to come to their facility or to vaccinate those individuals, and they can't do it. And when you say, well, you know, they're supposed to go to the providers are not wanting to provide that service. So I really implore you all, especially because this is such a special needs area, to reconsider and to try to work towards getting that taken care of. Thank you.
Okay. Mr. Deeringer?
Oh, I think he just had his community health worker update.
Oh, okay. I'm sorry.
Fatima, do you know what the vaccination rate is currently in the fee for service?
You mean at the primary care office?
Yeah, I mean, of the members that are fee for service, is it a high vaccination rate or is it a low vaccination rate? Like, I mean, it sounds to me like what I'm hearing is it's a struggle. And, you know, when we talk about wanting to get members vaccinated, if the number is already low, it sounds like it's a really good argument for allowing pharmacists to be able to do this.
Yeah, that's something I'll have to also take a look into.
Okay. Thank you for that information, Fatima. Is there any other comments on that topic?
Is this just a long-term care issue, or is this really Medicaid patients can't come in to a pharmacy? Medicaid fee-for-service patients can't come into a pharmacy and get vaccinated because we can't get reimbursed. Did I say that correctly?
You did. A fee-for-service patient cannot come into a pharmacy and receive a vaccine.
This is the first I've heard of this in the 12 states that I've worked over the last 13 years. Okay. I mean, I've heard of other barriers like VFC, like billing system not being in place, so only getting like maybe only getting a really small admin fee, but I've never heard of it not being allowed. Okay. News to me. I'm learning something new every day.
Okay. 5B, registering with UHC for vaccine counseling billing. Matt?
Yes. I recently was getting together with Emily Wilkerson Gatewood, who is running the program through KFHA from a grant from the state to get pharmacies set up to be able to bill for vaccine counseling. And during the steps she was helping with it, everything was running smoothly. She said, we've had issues with United Healthcare, so we went together on the website, tried to figure it out and register the way it wants us to. And it gave me a, sorry, you cannot register for this at this time. If you want to register using digital tools but remain out of network, go to this. and we tried different ways. It was just a circle and it was very confusing. And maybe it's not set up for pharmacies to register yet since it's new within Kentucky. I didn't know if it required a pharmacy to be CAQH. It kind of made it sound like that. It's just, there's very little direction from the United Healthcare website to set up to do this. It was fairly easy with almost nothing to do with the other MCOs that get set up for this. And I have a follow-up meeting with her today, and I just kind of wanted to get an idea of what to do, who to talk to, if someone from United Healthcare has insight that help, because I think I'm one of the first pharmacies trying to do this and kind of a pilot project at the time. So I kind of like to see if we could get this streamlined to make it easier for other people to take advantage of this program that Medicaid is now allowing us to do.
So are you also having trouble with other MCO vaccine counseling billing, or is it just United?
I'm going to do my first actual billing today, getting the tutorial for that. I was doing the setup with Emily, and the setup for everything else seemed to be fine. It was United. It was the one that was just an endless loop of different links, and then saying that you couldn't register. So I wasn't sure how to go about who to even talk to about this.
Yeah, and I did reach out before this call to the United Pharmacy director. I think she's out of office today. So if you don't mind just sending myself and CCing Quinlan Radcliffe, we can serve as liaison between yourself and United and get those issues resolved for you.
Okay, I appreciate it.
I'll put his email in the chat.
Okay, thank you. All right, the 5C could easily have been old business, but what I was wanting to ask Fatima is that the number one question I get from pharmacists is, I went over last time the negative financial effect it has on us with our buying contracts. And so, when you look at Adderall XR 25, a reimbursement was $215.80 for 30. That should be everybody's same across the board. And then when I look at a commercial on the generic, the reimbursement's somewhere between, it ranged from 28 to 32 along through there for the, same thing in generic. So I guess, no, I don't expect, you all to show us, or, it's proprietary, your all's contracts you do with the rebating program. But I guess logically people look at this and say, okay, you would have to get a $200 rebate on Adderall to make it, worth the cash outlay for your savings by dispensing the generic, or you all paying for the generic. So I guess if there really is that big of a rebate on some of these things, it would be nice to at least just do one example to show everybody, this is why we're doing this program, because it's a whole lot to reduce the net outlay of cash for reimbursement. So I didn't know if that was possible, but it's still the number one, because everybody comments on the difference in the brand versus generic reimbursement, and and with it hurting our bottom line, we just, everybody would like to know that, okay, there is a big difference in the makeup of on the rebates. So just want to get your comment on that.
Sure. So I think there was this, and I know we had discussed this years ago when MedImpact went live and we implemented the unified PDL, which, to your point, does prefer some brands over generics because of the rebates on the back end. And I remember sharing, and I'm going through my notes looking for it now, sharing a chart example of obviously fake numbers and what a potential rebate amount is for the brand and versus the generic, and how the generic could end up costing the state more money than the brand.
Okay.
So I will try to dig that out today and either throw it in the chat if I can find it during this meeting. If not, I'll just hit reply all and send over that example.
Okay, that'd be great.
Mm-hmm.
Okay. Do I have Angela Kamer-Lay on the line?
Yes. Can
Okay.
you hear me, Ron?
Yes. Yes, go ahead.
Sure. Thank
your
y'all
comments on this topic.
Sure. Thank y'all for adding it to the agenda. I have been working with my pharmacist, or excuse me, my pediatric medical director, Dr. Brashears, and she's reached out to Dr. Therio. We are trying to get an increase in vaccinations, especially HPV, but really adolescent vaccinations, because that is on the VBP program, the state value-based purchasing program, immunization for adolescents. And so we were wanting to especially reach out to the pharmacies and partner with them, especially since now they have the increased admin fee, the counseling, to where it's not even tied to them receiving a vaccine. They could just talk to the member or to mom or dad and still get reimbursed. But we're looking especially at areas that there may be like a vaccine desert. So maybe the health department in that area of Eastern Kentucky doesn't offer the HPV vaccine. We would just really like this opportunity to work with the pharmacists, and I think it'd be great collaboration across, MCOs and the pharmacies in the state to see these adolescent immunization numbers increase. And I think Dr. Therio was on. I didn't know if she wanted to add anything from the state's perspective.
Well, I think, when you talk about immunization rates, you can't just talk about one number. You have to look at it by each each vaccine. And when you look at HPV vaccine, it's very, very low. It's lower than we want it to be for all adolescent vaccines, but it's tremendously low for the HPV vaccine. And which, at least to me, says that it's not working. It's not being just not working, having that vaccine only available in the physician offices. And so opening it up to pharmacies, and you can start giving that vaccine as young as 9 years of age, hopefully can, and do a push for it, we can hopefully get that number up statewide.
And also my understanding, and Ron and team, you all will know better because you're out there living it, is that you have to have a protocol by a physician. It's not like the flu, where they can just walk in and get it. And that's where I was thinking maybe the state could come in, and a physician with the state could make that blanket protocol for any pharmacies in Kentucky.
So do we not have a Board of Pharmacy statewide protocol for, do we only have one for adult vaccines? Does Matt or Ron or Rosemary, do you know?
No, we've got the immunization. I mean, that's in statute. So, but you still have to have a medical director to sign off on the protocol and be in charge of that protocol. And it is just like, whether you're doing meningitis, whether you're doing the new RSV, I mean, it's just like that. So it's you registering that protocol with the Board of Pharmacy. So we just need to work hard, Angela, on getting more pharmacists aware of the need for it and asking them to develop their protocol and get it signed by their medical director to get this done. And of course, the Board of Pharmacy is compiling this data now, so you should be able to see, hopefully in a short time here, where you have more options throughout the state.
Well, and I was even thinking, Ron, since this is really a measure the state needs to hit. It's part of the HEDIS measures, that if they could partner by putting that protocol out for all pharmacies to kind of take some of the burden off the individual pharmacies, if they could do that, that would go a long way.
Yeah.
I think a statewide protocol can be helpful. Yeah. But I think Ron's also right that we have the authority to do it. I think, working with the pharmacies to let them know that you'd be, what the reimbursement would be, how they would bill, that might help. And I'm happy to, between the Kentucky Pharmacy Association, this group, and Kentucky Retail Federation, I'm happy to talk with you about what the full membership looks like of pharmacies in Kentucky and brainstorm with you.
That'd be great. I already have like a mock-up of a pharmacy provider letter. Of course, we don't own the network, so we're doing this, the vaccine counseling is built on medical, so we're coming in that direction. But yes, I'd work on this with you. I think that'd be great. And I think it would do a lot in the sense of the quality measures the state's really pushing for, and it'd be a great way for pharmacy to collaborate with that.
Angela, this is Rosemary Smith with KIPA, the Independent Pharmacy Group, and I would be glad to work with you as well to get this information out to our members. We have over 600 across the state.
Yeah, and Rosemary, I'm sorry, I did not mean to leave your group out.
That's okay.
We all work together. This is about access, and certainly the pharmacy community beyond the chains is very large. The independent community in Kentucky is very, very large and well placed.
Sure. Yes, so, it would be. We would need every pharmacy. I mean, it's not just the independents. It's not just the chains, because of course those independents, I mean, they might be the ones down there in those vaccine deserts. So I've worked chain and I've worked independent, so I've realized the benefits of both. So I will keep both of you all. If you all could put your emails in the chat, that'd be great. And we're going to move forward with this.
I think a statewide protocol is an excellent idea. I think it makes it easy for everybody, and it removes, all the barriers. And the easier we can make it and the most amount of barriers we can remove, I think the more successful the program will be.
I agree with Meredith. I think that a lot of pharmacies, that just, it saves an expense for them. It saves time to have to go through the process of getting your protocol upgraded, up and all that. So I agree.
Fatima, what do you think about that?
Sorry, just trying to switch screens there. Yeah, so I think it's a good idea. I think, it's a win-win all around. I do agree with Dr. Terrio and Angela's comments. I think let us take it back and just see what it would look like, what the logistics of it would look like, and then we can follow up with this group in the next meeting.
Okay, sounds great.
And then in 2 years, we can look and see what the percentage of HPV vaccine is for kids getting it in the physician office versus the pharmacy. Of course, pharmacy is going to be a lot higher, and then it will open up new, then we can publish it and go nationwide and tell people what they should be doing. So there you go.
Okay.
There you go.
Yeah, and I think if there's a program in place, that's when that's when there'd be more advertisement for it. Let's put it that way in the private sector. So.
Okay. All right. On 6A, and Fatima, basically, we've discussed these before. Is there any, point in time to, have a committee that just starts discussing these things? Because I know you've talked about your just building the network or building the infrastructure to handle, pharmacist clinical claims. I mean, obviously we're already doing some of that with the vaccination interview process. I mean, so, and you've heard me talk about, I mean, I know UK Med Center, as far as the compounding side, they would love to have some help on, because they choose to go ahead and just eat the cost of compounds because it's a better treatment for the pediatric patients. Or they're maybe changing the dosage form in order for the child to be able to take it. But I know, I mean, they're not the biggest, excuse me, the independent compounders are not the biggest pushers on this. It's really, the big hospitals that do a lot of compounding for pediatric uses that, go unpaid. And then, of course, I've talked to you about autism and ADHD patients and how nutritional supplementation would really be beneficial. I'm not ever promoting just, open it wide open, the Wild West of it, but just maybe take a disease state or two and be able to have a formulary, strict formulary on that. But anyway, just wanted to get all three together, all topics of those, and see if there's any way we can, in the near future, be able to form some work groups or whatever you want to call it to see if this could be brought to fruition.
Yeah, I think, this meeting, PTAC, is probably the best forum to bring up some of these concerns. I think we're all aware of the I guess barriers and roadblocks to having pharmacists bill for some of these clinical services. I think little by little we are moving towards giving pharmacists a larger platform per se, with vaccine counseling, for instance, vaccine administration. We have the fee-for-service, vaccines at the pharmacy in consideration, community health workers. So, I think little by little we are treading forward in that direction. I think really it's a matter of time. And I'm not, trying to say that we're going to make this change right here, right now. But I think, again, we're moving in the right direction. And I think evaluating all of these opportunities that have been opened up in the recent past, if you will, will allow us to really dive into the data, see what's working, what's not, and further evaluate change for the future.
Okay. What would you suggest now for us to do? Just send you more information about each of these topics, and obviously we're not the ones that's going to be building the infrastructure as far as the billing process and everything, but just give us some pointers on what would be useful to you.
I think here at Medicaid we make a lot of data-driven decisions. So if we can see data of perhaps something that's been working in other states that might be congruent in Kentucky, we would want to see that. I think especially for fee-for-service vaccines at the pharmacy, that's something where we have to kind of dig up notes and information from the past, and some of that precedes my time, so I might have to make a few phone calls and say, hey, what happened in 2020, 2021 when this was being evaluated. So I think it's something worth evaluating, but I do think we need as much data and evidence to back it up.
Okay.
Ron, this is Matt.
Yes, sir.
There'd be one thing I'd like to add for consideration to the clinical services you have already mentioned, which would be genetic testing. About 8 or 9 years ago, when Medicare was paying for it, I was doing it for a number of patients, and some patients you didn't really see that there's nothing to change, but there was a number of patients you'd find that they weren't even metabolizing the drugs that they were taking, so it was kind of useless to have them on it, and you could switch to a different drug that would actually work. And I think that could lead to less spending on Medicaid's part to where we could actually get people on medicine that's working for them. Or if they're a slow metabolizer, it would make sense that we need to increase their dose or lower the dose depending on how it goes. But I thought it was a very good program. I was disappointed when Medicare stopped covering it, but I think it'd be worth looking into for Medicaid.
Okay. Well, what we got to do then, Matt, is get some, maybe there's some studies out there, or just look at some other states. And like she said, we just got to get the data put together that can hopefully show the savings. But you're right. I've seen the same thing. And especially in the mental health category, you have a huge need for genetic testing, because when you do see the results of those, it truly is eye-opening to see a good portion of even the same class of drug, but like a third of them are, ruled out as far as a good candidate for that patient because of their lack of enzymes. So it's a good point.
Yeah, I noticed that NCPA put out that Wisconsin Medicaid is implementing provider status for pharmacists. I think they passed it back in 2021, but the implementation is actually beginning. So I'll try to research what in Wisconsin what services they're being reimbursed for.
Okay. All right.
And Ron, do we need to make like an official motion on our recommendation on like the fee-for-service reimbursement for vaccinations and the HPV moving forward, or was just things we're going to follow up on next time?
Yeah, and that's my fault. That's been a request of the MAC, is to have the action items, because they're limited in their time, and a lot of times if we're not having action items on that, then we don't. But just going through today, we talked about Senate Bill 50. We know about that. There shouldn't be any action items there. I think Jill's going to be working behind the scenes on the VFC. Community health workers, Mr. Derringer's gave us an update on that. I think we're feeding them information to help out with that decision. But yes, if we could have a motion on the fee for service, that, I mean, I would just, not trying to put words in somebody's mouth, but to where we are for fee for service reimbursement for vaccinations.
I'll make that recommendation that this committee would like to see Medicaid reimbursed for fee for service vaccinations.
Okay.
And I will second that.
Okay. First by Meredith, second by Matt. Any further discussion? All those in favor say aye.
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 And Ron, this is Erin. If you don't mind to follow that up to me in writing, that would be great.
I sure will.
Thank you.
Just writing my notes down here. Okay. Let's see. Just looking through the rest of stuff.
Ron, would the other one be that we'd like to have the state have a state board protocol or the
when they see the need for increasing, well, if they just see the need that we need to be getting either increased vaccination, or maybe there's another service. But I definitely think in this particular case, in order to try to increase the numbers of HPV through adolescent vaccinations. So anyway, do you want to make that motion, Rosemary? Okay. Motion by Rosemary.
Second.
Second by Matt. Any further discussion? All those in favor say aye.
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 Okay. And as far as the rest, I mean, this is a project that's going on in a lot of states right now. And I think if we can do our research first, and then we might have some action items later on. But the biggest thing is we we need to compile data. And then we got something more concrete, or we see a need that we want to, prioritize. I think that's where we can have action items there. But I appreciate Fatima's comments about, they're just needing information on kind of where to go. And I think with all of this, the number 6, that's what all the pharmacists that I know are doing in the state right now anyway, is trying to work with the different insurance companies and build these networks for doing the clinical billing. So is there any other action item you all see needs to be on number 6?
I think we're in a data gathering stage right now, and it'd be premature to make a motion for this.
Yeah. Okay.
Ron, can we make a motion that the state consider putting out a bulletin informing enrolled providers specifically about the change in VFC?
That's motion by Jill.
I'll second that.
Second by Rosemary. Any further discussion? All those in favor say aye.
Aye.
Any opposed? And Jill, what was your specific wording on that again? I didn't get all that.
I put it that Medicaid do a communication to pharmacies, alerting them to the rule change that allows them to provide vaccines to children enrolled in Medicaid, in conforming with the state law, the State Practice Act, 9 years and older.
Okay. And I'll send that to you, Jill, to make sure I got it right, and then I'll get everything to Aaron.
Okay.
Okay, the next MAC meeting will be November 30th, where I'll present
or December 13th. Is it December 13th?
No, November 30th is the MAC meeting. PTAC meeting is December 13th.
I'm sorry.
So I'll be presenting our motions and action items, and we'll get that out to them. And then, like I said, December 13th, we've got some stuff to look forward to that'll be more complete at that time and more discussion. So anybody else?
Ron, I have a couple of things to add in general. The first one being, brand over generic switches and how that works behind the scenes for the state. I did just pull a presentation 2 years old that MedImpact gave at one of the provider webinars and send that to everyone who's on the invite.
Okay.
Feel free to take a look at that and let us know if you have questions. I did also put another chart that I came across, which I think will be helpful for everyone's understanding of how this, how the convoluted rebates work. So hope you find that helpful. Again, if there are any questions, we're happy to discuss them, or you can bring them to a MedImpact webinar and we can use that as another forum to get those questions ironed out. The other thing, speaking of MedImpact, is, I think most of you know this and anticipate, quite a few notices and provider webinars to discuss is the switch from Magellan to MedImpact in terms of fee-for-service claims processing. So it's just a switch of vendor, which means that a couple of billing practices will change, but it won't be a monumental change. So the BIN number and the group number are the two billing pieces that will change, and these will be discussed extensively in the next MedImpact provider webinar, which will be on November 16th. So keep an eye out for that. We'll be sending multiple notices to pharmacies throughout the state, letting you all know when the webinar is. I do think it's very important for folks to attend that webinar. And, keep an eye out for notices so that when 2024 comes around, you guys are billing appropriately and, there are no issues there. In addition, MedImpact has kind of general mailboxes for the MCO members, and then there will be a fee-for-service mailbox as well that you can email any concerns or issues to. Some important payment timeline information will be discussed, as well as where to submit prior authorizations if a prescriber is having trouble getting through to MedImpact, where you guys can come in and help in those situations. So lots of important information. And aside from claims processing, as you all know, Magellan does our rebates and PDL services. So those will also transition to MedImpact. Now, with that being said, we anticipate a few PDL changes, but they will be minor changes. So, we're not going to dive into the GLP-1s, for instance, and change a bunch of things in there. Really, we don't anticipate the member impact to be substantial. There will be some, with the vendors changing. But again, we don't anticipate it being as burdensome as some other maybe P&T changes might have been. But with that being said, we do encourage you to join the next P&T meeting to see what the outcome of those recommendations are. And in addition to that, there will be a transition of items on Magellan's website to MedImpact's website. So MedImpact's website is not changing. It's just that on 1/1, a couple additional documents and such will be uploaded, and everything will be triaged to MedImpact from that end. So, keep that in mind. Again, if you have any questions, feel free to email myself or MedImpact directly. And I can throw the general MedImpact email in the chat. Any questions?
And Erin, can you make sure all the information she's putting in there that we all get?
I've already got it copied in an email for you guys.
Okay, thank you. And I'll make sure everybody else gets a copy too. So, okay.
Some of our will be asking if they're already contracted with Magellan, will that contract go over to MedImpact automatically with fee-for-service? Would there be anything they'll need to do?
No. So as long as the pharmacy is enrolled with the state, it'll be business as usual. But let's say a pharmacy has both MCO and fee-for-service members, it'll just be a different BIN and PCN that they'll be using.
Right. Thank you.
That's a nice transition, Rosemary. We usually don't have those easy transitions.
Yeah, we're hoping that, this will really just identify all the problems, go to one vendor, one-stop shop. So we're excited.
Sounds great. Okay. Thank you all for tolerating my IT goof up at the start. So thanks for that. And do we have a motion to adjourn?
I'll make a motion to adjourn.
I'll second.
Second by Rosemary. All those in favor say aye.
Aye.
Any opposed? Motion carries. Y'all have a great afternoon. Thank you.
You too. Thank you.
Thank you.